Hi, good morning, everyone. We're going to go ahead and get started with our 11:15 session, PI and Aging. My name is Megan Messick, Director of Education here at the Immunodeficiency Foundation, and I'm honored to be your moderator for this morning's presentation. This session is going to be 45 minutes in length, and we are hoping to have time for audience questions at the end. So always a good plug for my friends sitting in the back to come join us in the front. It'll be a little easier to get you a mic if in the event that you have a question for us at the end of this morning's program. But before we get started, I just have a couple of disclaimers that you've likely seen on other presentations this week. The first is that the information presented in this session is not intended to be medical advice. Always seek the advice of your physician or other qualified health provider. In addition, IDF offers a wide variety of educational programming, including those developed by healthcare and other life management professionals. Similar to other sessions, the views and opinions expressed by our guest speakers do not necessarily reflect the views of IDF. But it is with great honor today that I introduce our presenter, Dr. Roger H. Kobayashi. Dr. Kobayashi is a clinical professor at UCLA and has been teaching, doing clinical research, and seeing patients for 50 years in Omaha and Los Angeles. You can read more about our presenter's biography by visiting the speaker section in your conference application. But it is with great joy that I welcome Dr. Kobayashi up here to the podium. Thank you.
Thank you. Thank you. Hi, I was teasing Megan and the other fellow. I said the reason why I sat up there is I wasn't sure I could walk up the stairs by myself. Getting older and older. First of all, I'd like to thank the IDF and Jory and others, Megan, who have done a wonderful job. I mean, this is really spectacular. Over 1,000 people have attended. The audiovisual is absolutely spectacular. And for an old geezer who, like me, who started in 1977 as a fellow, the audiovisual was so much better than the old slides that we had back in the old days. Now, I'd like to change my talk a little bit because I've given this a number of times, both for the IDF, for the Quad AI, and others. And what I'd like to focus on is really some of the complications that we had in primary immune deficiency. I'd like to also talk about immunosenescence. I don't know who made up that word. It's a horrible word, but what it means is when you get old, your immune system kind of conks out. And I'll show you a slide of a brand new BMW, and then what happens when you run around for a number of years. You know, your tire gets bald, your brakes don't work, your battery doesn't start quite as well, your steering wheel doesn't go where you quite want it to go, and your windshield is blurred. And that's what happens to us, and that's what happens to our immune system. And then when you throw, I mean, I heard there's a couple of Hawaii people here, or registered. So I may throw in some Hawaiian pidgin just for those individuals. So let's get started. Kahuna Lapa'au, that means a Hawaiian doctor, and I am a grandfather from Nebraska. You can see the disclaimers. And that little guy that I'm holding is now 5 feet 11, weighs 150 pounds, and plays quarterback for high school. So it's going to be the other way around. He's going to be carrying grandpa. Okay, let me put this up because I think this is important. You know, when you're young, you think you're smart. And then you find out as you get older, you're not so smart. And about 40 years ago, I was chair of a seed grant. Nebraska had a seed grant taxing cigarettes. And so this was for research. And a nurse presented or gave a grant, submitted a grant on old people falling. And I thought, what a stupid grant. I mean, you know, we're doing research here, lab research. I mean, who cares about old people falling? Well, go forward 40 years to that old doctor that you see over there. That old, arrogant young man turned out, hopefully, to be somebody a little bit wiser. And one of the things I found is that we have made a serious fatal disease into a chronic disease with a whole myriad of issues which we'll go on to talk about. And so what we'd like to do is to call attention that not only are we causing or the wonderful idea of having patients live longer, but we're also diagnosing them a lot later. And I'll show you some data from the Italians where they're diagnosing CVID at age 70. And a lot of these patients are getting older. In Italy, again, the average age of diagnosis for CVID is 40. And when I was a young man, I'm a pediatrician, so they say, what the heck is a pediatrician doing worrying about old people? Well, it's a natural progress because we've taken care of kids who have grown up into adults who are now getting older. And they have started a whole new slew of problems, which I'll go on to talk about. I'm going to let me pick this up because when you get older, your eyesight is not as great. And what I want to say is that, there are biases that I have. And I'm not criticizing what has been done before. There's enormous things that medicine has done, insurance have done with Medicare and all of those. And we greatly recognize the strides that have been made for the aged. But the aged have a lot of problems like diabetes, heart disease, kidney disease, arthritis, and all these other problems, and immune deficiency has to fit in there. So the way I look at immune deficiency is like we're a pebble in the shoe. We bother the giant, but we are there. And I think we need to make more noise, and we're going to talk about that a little bit. It's under-recognized, it's underappreciated. We've been saying this for 20 years, but it's still. You talk to a lot of doctors that say, oh, people don't have this problem. And if they recognize that they have this problem, they don't recognize a slew of other problems that are difficult. This group also has concomitant issues. I mean, diabetes is a huge issue which suppresses the immune system. So does heart disease, so does chronic renal disease, so does cancer, which a lot of older people develop. And so does all of these wonderful medicines and biologics that we're giving that create secondary issues. The other thing is our healthcare is fragmented. And I listened to that young woman that came up and complained about electronic medical records. And I said, if I was 21, I'd go up to the mic, put my right arm, and say, power to the people. And the reason why is because the healthcare system is dictating to the patient what they can do rather than the flip side. The elderly have a diminished and aging immune system with immune dysregulation, which may result in problems much greater than in the younger population. This is underappreciated. The other thing is that now, in the old days, people used to come to our office, get IVIG, and we took care of everything. Now they want you to take care of everything. And not only do they want to do that, they tell you, go on the internet, get on the information, and it'll show you what to do. Well, one size shoe doesn't fit all, and this is the problem. I'm a 60s generation, and I think when I was about 12, President Kennedy came into office, and he was kind of a hero. I guess the more you find out, the more they hid things, but he was a hero. And he said, ask not what others can do for you, ask what you can do for your country. And I think the same thing we should be asking. Ask not what the elderly can do for you, ask what you can do for the elderly. And this is what we need to tell the healthcare system. Who do they serve? They serve the people, not themselves, not to the convenience of themselves, not like UCLA, I can say this because I'm there. We only infuse Tuesday, the fourth Tuesday in the afternoon, and if you're not there, too bad. That's wrong. We have to accommodate the patient. And so why worry about all kinds of things? Well, I'm fourth generation Japanese, but I think Japanese have few sayings that are useful. One of them is Koromo no Tatami ni. This means for the sake of the children. So for the young children who have immunodeficiency, we want to see them grow up into healthy human beings who are productive and have a high quality of life. But it's the same thing for old people. Because when I was a medical student, they said, old people, put them in the corner, they've lived their lives, goodbye. Wrong. Old people like Dr. Ox, who I think is in the audience, rides his bicycle in Croatia, manages to weasel his way into a party for $30 and gets a free breakfast in the morning, and is 89 years old. I mean, look at Dr. Ox as an example that we all should look forward to, even if we have immunodeficiency. And again, Japanese, okage-sama de, that means I am what I am because of you. And a lot of times we forget people like Bob Good, people like Dick Steam, people like Ralph Wedgwood, all of these great individuals shouldered, we stand on the shoulders of giants, and we cannot forget this. And I was talking to somebody outside. I said, in the old days, we used to give gamma globulin injections. Kids hated it. Everybody hated it. And then people like Charles Janeway would try to make the thing safe in his laboratory, and then he would take that preparation, inject it into himself IV because he wanted to give it to IV. And he put himself into septic shock. He get staph infection, and then he had all kinds of complications and headaches. Over a period of time, we went from those very crude products to fourth generation IVIG to subcutaneous gamma globulin, and we're trying to make it safer. Well, terrific, but there's still issues which we have to address, and we'll go on to talk about some of those. Okay, a little bit of preamble, and then I'm going to speed along. It has been a privilege to witness the spectacular progress made since I was a fellow in 1977. Back then, clinical immunology was a descriptive specialty. If you had an unusual looking face, if you had eyes that were a little bit different, if you had low-set ears, if you had a lot of eczema and all of those kinds of problems, and you had a lot of infections, we said you had immunodeficiency, but we didn't know what kind. It was descriptive. And most of those patients died. When I was a fellow, we had a number of skin patients. And I hated it because I said, God, I should have gone into pediatric oncology. That would be more fun. Look at what Dr. Buckley and others have done now. 95, 96, 97% survival rate. These fatal diseases are now being corrected, including diseases like fatal chronic granulomatous disease of childhood, where people like Don Cohn now are doing gene editing. People like Hans Ochs and others have done bone marrow transplants to cure these people. Look at CVID or antibody deficiencies, which are by far the most common immunodeficiencies that we have. In 1969, the British surveyed, and out of that, if you look, after 12 years, only 30 were still alive. Look at the data coming out of Oxford with Helen Chappell and Charlotte Cunningham-Rundles. 45 years later, look at how many people are still alive. And we're improving on that all the time. But it's kind of like any good thing that you do, you create more problems. And what have we done? Most of these patients, especially antibody, we can treat, but we cannot cure. And that is a problem because now they go on, the longer they survive, the more of them have problems. And Charlotte's paper, which I've referenced in Blood, showed that, about a third of the patients these are CVID patients, only had infections, did spectacularly well. So Manish Bhutt I wish I had put that chart, But here's a lifespan over 40 years for regular people, and people with CVID that had only infections went like that. But if you look at the people who had non-infectious complications, it went almost in half. And while we're improving on that, we need to do more. And that is markers, clinical and laboratory markers, which Mark Rydell might have talked about, but also not only those kinds of things, but to make sure that patients get access to high-quality care. And I had to laugh yesterday when I heard Manish talk, because he was saying, no use talk to pulmonologists or rheumatologists or neurologists anymore. And I was thinking, yeah, I was saying that a long time ago. But I don't think we can give up. But we need to recognize that immune deficiency can present in so many different ways, and we're learning. And yet, most doctors don't know that. You have inflammatory bowel disease, what do? They give you all kinds of immunosuppressives and toxic problems, and they never think that you might have immune deficiency that you might be able to treat effectively. Okay, there are three huge issues. One, of course, we've talked about before, and we've given you references, and I think there's some talks by the IDF on this. But the main idea is that not appreciating that immune deficiency is not rare. Not rare. And it's getting more and more common as we diagnose more of these patients, and they're living longer. The second thing is not appreciating the unique characteristics of this age group. They have immunosenescence, they have concomitant heart disease, liver disease, kidney disease, who knows? They can't see well, they can't hear well, they can't drive like the way they used to drive, they can't get around, and they have all kinds of issues, social, economic, cultural issues, separate from the medical issues, that we do not appreciate and we don't address. And this is something that we need to work on also. I mean, who cares if you have gene editing and you can fix something, but it costs $2.5 million? And these are the kinds of issues that we need to think about also. And the big issue, this is a chronic disease. And there was a wonderful paper that I'll talk about briefly from the ECID database. And what they showed was the burden of disease for CVID is just as great as somebody who has had stroke or severe heart disease. The reason why it's under the radar is because there are few compared to people with strokes and whatnot. But what this article was saying, the Europeans were saying, is that this is just as an important issue because it can be debilitating, costly, and impair the quality of life for people with primary immune deficiency. And this is what we need to let people know. You know, I'm from Hawaii, so we don't try to slay giants. We just try to get under their skin. So I love the idea. I'm the stone in the giant's shoe that annoys the hell out of them. And that's what you guys gotta do. You guys gotta advocate for yourselves because these are issues that are building up and need to be addressed before they get worse. I'm not gonna spend too much time on this because we did it in previous lectures. But you know, when we were young, I mean, we were all Ferraris and bright, shiny BMWs. Our immune system was working great. Our heart was working great. We could see well. We could hit golf balls 300 yards. And then as we get older, not only does our body not work as well, but our immune system doesn't work as well. And put on top of that, superimpose primary immunodeficiency on all of that. And like they say in Hawaii, hey, bro, jam up, man. And what that means is things are not great, and we need to make sure that we address those. Okay, so how did we get concerned about this? Why would a pediatrician get concerned about this? Well, I had an Aussie and Harriet couple. Wonderful. She was sick all the time. The pulmonologist finally sent her. We discovered she had CVID. We treated her first with IVIG. She did well. We transitioned her to sub-Q. They were happy as a clam. Every time I came in, I said, what a wonderful couple. And then the husband developed Alzheimer's. And she worried about him to the detriment of her own health. And in addition, as a caregiver, he was not able to help her. And what happened? She died. And that bothered me. And so I said, Laura, what the heck is going on? Let's see how many old people we have. And I thought we had only 20. Well, it turned out we had 80 in our practice. I called Ralph Shapiro in Minnesota. I said, Ralph, I got 80 people. How much do you have? He looked. He had 80. I called Mark Stein in Florida. And Mark laughed at me. He says, Roger, I got 100. We were shocked. Between Ralph and I and Mark, we had almost 300 patients over the age of 65 on gamma globulin. Wow, what a surprise. I'm going to bypass a lot of this. But our eyeballs opened. We presented this data at the CIS, and everybody was surprised. Everybody was like, wow, just like us. Here are all these old people, or I shouldn't say older people. Charlotte poked me in the chest the other night saying, you shouldn't call them older people. Experienced. We're amazed. Look at the data that we were seeing. The minority were young people. The adults and older people were the majority. Why? Because the success of keeping them alive, the success of better diagnosis, making the diagnosis later. Okay? Two ends of the spectrum. I love this thing, and I'm glad they still let it in. A lot of my cartoons and things were taken out because we couldn't get copyright approval. But imagine the immune system of a young baby or a young child. It's immature. And so they get a lot of infections, of course, because the immune system is not primed to or know how to fight infections. They have to learn. They have less response to vaccines, and they make mistakes more. So they get allergies and things because they have a vigorous immune system, but it's not as smart. Flip over to the old people. That's why I kind of think that being a pediatrician but worrying about older individuals is not crazy. It's two ends of the spectrum. And older people can't do things as well, just like younger people can't do things as well. You're not going to tell an old guy that's 85 years old, okay, you're going to play full court basketball for 60 minutes. They can't do it. But it's the same thing. The old people's immune system wears down, it doesn't function, and it's set in its ways. It really is. I mean, we can show you laboratory data, but basically that's what happens. Okay? Our immune system deteriorates. We have more infections. The response to infections are not as good. And one of the problems with older people is that normally when young kids get an infection, they have fever and they have symptoms. Old people sometimes have infections, but poor, diminished inflammatory response. And that's why they have more problems with infections. Their immune surveillance goes down. What is the impact of all of these? Well, we know nutrition impacts the immune system. Diabetes impacts the immune system. Liver disease, kidney disease, all of these kinds of things impact the immune system. And superimpose that all on an elderly person. And the Hawaiians have another word, pilikea. That means, hey, that's bad news, man. You know, they say you can take the boy out of the islands, but you cannot take the islands out of the boys. So if you guys, any of you Hawaiian guys are out there, I can still speak the kind. We have a decreased ability to make cells, and make cells that can adapt and function well. T cells, B cells, we make less of them, they don't work as well, and we have chronic inflammation. We'll skip this, but basically, again, the big message is you don't make enough of these cells, you don't make cells that can adapt. The cells that you have don't adapt well, and they don't function well. And as a result, you have more infections, you have more cancers, you have uncontrolled inflammation. And the way I look at inflammation is kind of like you have a faucet. You turn the hot water on when you want hot water. But when you turn it off, the faucet doesn't quite shut. So you leak. So what happens? You have low-grade inflammation, and that damages the joints, damages the liver, and damages other organs because you have this low-grade inflammation. Also the lungs and the sinuses. Oh boy, immunosenescence. I think we talked enough about that. I mean, the immune system gets old, it gets tired, same old, I'm running out of gas, and so you get more problems. Here again, I'll kind of skip over this because of the sake of time. But the main thing again is if you look on the left side, the young people, they have a lot of cells that can differentiate and function. And so you have cells that are the part of the innate system. These are cells that go after things without being programmed or told to do it. They do it automatically. But one of the things that young people have is they have a lot of these cells for adaptive immunity. And that's important because how do you know what you're going to face? Let's say for whatever reason, they say, okay, you're Japanese. So your immune system is only going to respond to Japanese things. Well, when my great-grandfather came to America, I wouldn't be around if my immune system weren't be able to adapt. Well, the problem is when you get old, you lose this ability. And that's the issue. And that's kind of the way things are. Okay, let's skip that. Again, we're being repetitive, but the results of an aging immune system, increased infections, so problems with bacterial infection, problems with viral infections. If you look at COVID, 95% of the people over 65 were the ones dying. The other thing is that when you give them vaccines, the response is not as good. And that's why if you look at the varicella vaccine, it's more potent. Now we have to get the pertussis vaccine. That's more potent for older individuals. We have to get killed vaccines, which might not be quite as effective as live vaccines. But killed vaccines are important in immune deficient patients because if you give live viral vaccines or live vaccines, you may create issues. And so these are all of the things. The system doesn't recognize malignant cells. We're all developing abnormal cells, and the immune system helps to get rid of them. But if it's not working as well, more malignancies result. If you have inflammation in the gut all the time, that creates inflammation, stimulus perhaps for developing abnormal cells, which may then go on to develop malignancies. Okay, so what's the problem? The problem is we have made medical advances, and antibiotics, which came out in the 1940s, were breathtaking. People who used to routinely die from bacterial infections, pneumonia, sepsis. Imagine in the old days, you got a puncture or you scraped your knee, and then staph or group A strep got on. You could get sepsis and die. Women getting sepsis from childbirth. Now it's almost unheard of because of antibiotics and vaccines. So the big improvement was in the 40s, and that's kind of how we found out about immune deficiency. We gave antibiotics to all these kids, And they kept getting sick, and they kept getting sick, and they kept getting sick, just like the classic patient that Colonel Bruton presented. That kid had something like 28 pneumonias and hospitalizations and was on antibiotics. Obviously, without antibiotics, he would not be around. And we'll show you some data about Hans and Aaron Chin and some of the others looking at people with XLA who are old. And if you look, a lot of them had older brothers, cousins, uncles who died. And that was because before the recognition, and Dr. Ox has rightly said, that antibiotics probably helped the lives of many of these. After that, there were still people who still got a lot of infections with antibiotics, and then we began to recognize that maybe something's wrong with the immune system, and that's exactly what happened. And so for people with antibody deficiencies, obviously, gamma globulin was a major advancement, and probably, at least for people with antibody deficiencies, antibiotics and the replacement of gamma globulin have prolonged life and the quality of life. And I think this is critical. They're living longer now. We have advancements in therapy, bone marrow transplants, particularly for the diseases I mentioned earlier, gene therapy, gene editing, monoclonals, all of these kinds of advancements. But the most common problem, that is antibody deficiency, is, for the most part, treatable but not curable. So in the next 12 or so minutes, we're going to go over some of the data from the Europeans, from Charlotte's group, and then from ESID. Okay, this is a great paper. This is from, and Hans probably knows this group, they're from the middle central part of Italy. They looked at their patients. They wanted to see what happens to older patients. So they had 78 patients, and this is based on the age at diagnosis. So out of the 78 patients, 65 were younger, 65 patients were younger than age 65. This is the diagnosis was made before age 65. But the other amazing thing is that after 65, there were 13 people who were diagnosed with CVID. What does that tell you? That old people are being diagnosed with CVID. If Charlotte were in the room, she said, "Rogers," and poked my chest again. Experienced people. 70 years old was the average age of diagnosis. And they followed them for about 8.5 years. And if you look on the column on the left, that is diagnosis made before age 65, a couple of things stand out. One, females more than males. And this is a thing that we got to get away from, because when I was a fellow, it was said that this is a disease of infants and children, predominantly in males. And that's true for children, but not for adults. If you look at the Mayo Clinic data that came out a number of years ago, 80% of patients had antibody deficiency, adults had antibody deficiency rather than some of the other forms of immunodeficiency. So females more than males. The age that they had symptoms, about 30. The age of diagnosis, about 40. Now look at the other side, those diagnosed after 65. Imagine 13. And there are papers that show, the ESID data shows where you have older people being diagnosed. So it's wrong for internal medicine people to say older individuals cannot have immunodeficiency, let alone adults cannot have immunodeficiency. Wrong. They're the ones that get it. And look what happens. The take-home message of this thing is that if you looked at the people diagnosed under 65 as you followed them for 8 or more years, a number of them developed complications. What does that mean? That just because you diagnose a patient, put them on IVIG or sub-QIG, you don't throw them out the door and say, come back when you're sick. Wrong. You have to be following these complications. And you can see during the observation period, those under 65, 12% had autoimmunity. But after you followed them for a number of years, that percentage went up to 30. The same thing with polyclonal gammopathy, the lymphomas, et cetera, 3%. And then as you followed them, these are under 65, 13%, it went up. If you look at GI issues, that went up. If you look at cancer, that went up. And if you look at Charlotte's data, it's a little bit dated, but she said, you know, the main cause of morbidity and mortality in CVID patients were lymphomas, severe chronic lung disease, liver disease, and GI problems. What does that tell us? I mean, you don't have to have, a golf ball hit you in the head and say, hey, something's going on here. I mean, we need to recognize the risk factors and try to prevent them if we can. And some of Charlotte's data, and I'm sure people, Hans and others, have more important data, but Charlotte's data said that if you had low immunoglobulins, you're more likely to develop autoimmune disease. You had low lymphocyte counts, you're more, low B cells, more likely to develop lymphomas. These are some of the markers, but we're getting much better, and we have to do better. This is a great paper. And it's really a lot of data, but I'm just going to tell you a little bit, and the reference is there. The Europeans have a registry, and they looked at it in 2018. They had 2,700 CVID patients that they looked at for a 10-year period. What they saw was bronchiectasis was about 22%, autoimmunity was about 23%, GI diseases 15%, solid tumors 5.5%, lymphomas 3.8%. This is an outstanding paper. It stratifies what happens, and interestingly enough, the younger the diagnosis, the more impact it had on the quality of life. So young children, teenagers, young adults, it impacted their quality of life. And that became less so as you got older. Why? Because when you got older, you got a lot of other problems, like heart disease, arthritis, etc. But the point being still, it would have been interesting to see what the incidence of these were according to age groups. And this was not in the paper. I'm sure it'll come out later. Complications were frequent and even more so as patients got older. And that we showed you in the Italian paper. Note the high rate of complications, and note in this paper it demonstrated that despite immunoglobulin replacement, half of the complications were due to bronchiectasis. This next slide is fabulous. I mean, it's a little bit complicated, but I think they'll make it available. The statistics is difficult to understand, but the burden of disease, kind of what that means is what is the factor of premature death and disability. And if you look at the brown is like kind of the normal population per 100,000, and you look at the blue, and that's people with CVID. And you can see for digestive diseases, the burden of disease is much higher for digestive disorders. And remember what Charlotte said, if you have GI issues, that may lead to a shorter lifespan. So this is something that needs to be looked out for and addressed. Look at the incidence of lymphoma, brown and solid tumors, brown versus blue. The blue is the immunodeficient CVID patients. Look much higher it is. in terms of a complication. Look at autoimmune problems, ITP, alopecia, rheumatoid arthritis, diabetes, hyperthyroidism, all more frequent, more cause of disability in patients with PID than in the normal population. Look at COPD, again, more. Asthma, maybe not as much, but still more. And then look at bronchiectasis, enormous. Okay? Just really briefly, Hans and Aaron Chin and others, what we want to do is to look at patients with XLA. These are patients who are born with it, so they're perfect people to study. And we found about 26 of these individuals still alive or just recently passed away at age 60 or more. And what you can see is that most of the diagnoses, they had a family history, they had a brother, or like I said, or a cousin or somebody who got sick and unfortunately passed away. Most of the diagnosis was made very early, and only one was made in adult. And what we're hoping to do with the help of others is to look to see whether we can get a genetic profile. The question we're asking is, why are these individuals, why did they live so long? What can we learn? What are the complications so that we can learn and help prevent these complications from occurring? Okay?
Kobayashi, we are actually just a couple minutes out.
Okay, so I'll finish in 1 minute. How's that? Here's the data from Charlotte. Mortality was 11 times greater in patients who did not have, had non-infectious complications. This is a paper you ought to look at. And the average age at death was in the 40s. It's improved a little bit, but we want to do a lot better. And then there was a paper that showed that if you do gamma globulin replacement faithfully, you will do much better. Okay, let me go very quickly. Just really quickly, internet technology is wonderful, but it creates a whole bunch of other problems that you can see. We can't communicate with it. It communicates in the way that it wants to. It's so complicated. Medicare, wonderful, but it's like the 1,000-pound gorilla on steroids and amphetamines. I mean, it is just difficult to. We need to simplify, we need to minimize the self-interest, we need to make these programs and the websites trustworthy. I don't know about you, but when I get these solicitations or this information, you're afraid to click it on. I mean, is this a scam or what? And so we need to make that reliable. Okay, we need to make sure that people, simple things like self-managing gamma globulin, we need to make sure that individuals can do it. And this is a great problem for adults, which we can talk about if we have time in the QA. Okay? What do we need to do? We've talked about this before. Put your paddle in and join the effort. We need to recognize, do research, anticipate the unique needs of individuals, but just as importantly, the elderly need to strongly advocate and become involved on their behalf, their own behalf. If not you, who? We need the IDF, which they're making efforts on, Medicare policymakers, to be aware of this issue. And if you don't make noise, who will? And when I was in high school, this is the last slide. When I was in high school, George Bernard Shaw, some men see things, and I should put really women in there because women see better than men. Some men see things as they are and ask why. I dream of things that never were and ask why not. Okay, thank you.
Thank you so much. Dr. Kobayashi, we need to get you an extra hour next time. I want a little more. Thank you so much for that wonderful presentation. If folks do have questions for Dr. Kobayashi, we will actually be doing another session in this room very shortly. So I would just ask that you guys grab him out in the atrium, and he'd be happy to continue chatting regarding this very critical topic.